right, here we go. On the external view, we are able to keep in mind this is the left side that we're viewing. So from the external genitalia, we see the right labia majora, the clitoris, and this would be the left labia minora. This is still an ischium, and so like males, females do have an ischiocavernosus muscle that becomes part of the external genitalia. We're looking at the urogenital diaphragm, also known as the levator ani muscle, and this is the pelvic diaphragm. And the significance we're going to see on the cross section, sagittal section. We then have the urinary bladder, the vagina leading into the uterus, and the uterus is flexed over, sitting on top of the urinary bladder. And then we note there's the rectum. When the uterus folds over, it forms what we call a vesico-uterine pouch, and we also note a recto-uterine pouch. When we look at the side of the uterus, we note first, this is the cutaway round ligament, which helps to suspend the uterus from the pelvic wall. It looks like a tube. Yeah, that's the cut fallopian tube leading into the fundus of the uterus. And this would be the cut ovarian ligament, which is one way that the ovary is anchored to the uterus. The other side of it, we'll see, it's anchored to the pelvic wall. So now that we're looking at the actual sagittal section, we're back to noting, well, there again is the labia majora, the section of the clitoris, the labia minora, and so the area here represents the vestibule, meaning the entranceway or exit way from the urethra, and entranceway, we would say, to the reproductive system. And looking at the urinary bladder, same thing we note, we have a detrusor muscle, we see rugae, but note that we do not have an internal sphincter here the way we see with the male. We have a long neck of the bladder, and the streaks that we see across from here correspond with the urogenital diaphragm, and so we are looking, in fact, at both the internal and external sphincters. So that's why they are located in the same spot right over there. We're going to look into the cavity from this angle, so we would be able to note first the round ligament anchoring again the uterus to the pelvic wall. We then see the fallopian tube, and the fallopian tube is holding on to the ovary. We see the ovarian ligament going to the body of the uterus, and then we see where the ovarian tube, uterine tube, fallopian tube seems to come to a bend, and that's what we call the ampulla. And this is where the suspensory ligament pins the fallopian tube to the pelvic wall. What we would also note here is a broad ligament, which doesn't show very well. It does on the diagram that's in the lab book. If we had dissection with a cat, we would be able to note on the female uterus or the female cat's uterus, we would be able to see the broad ligament. And so to better exemplify what the fallopian tube looks like or its placement, this is my impersonation of the female reproductive system. So there you go. And that's just it. We're basically looking at how the fallopian tube seems to hold on to the ovary. The little fimbria, or motile, the opening into the tube, is known as the infundibulum. The bend of the tube, that's a suspensory ligament, pins the tube to the pelvic wall, is known as the ampulla, and then the rest of the tube leading into the body of the uterus, the top end of the uterus, is known as the fundus, This is known as the isthmus. Fertilization actually occurs in the ampulla.
Wow.
Doesn't happen in the body of the uterus. A sperm finding an ovum in the body of the uterus is like you telling a friend of yours, I'll meet you at the mall. They say where, and you say inside. It's never gonna happen, okay? And that's why we're looking at a tiny confined space. So that's where fertilization generally occurs. This is why, as we mentioned earlier, it's intrafallopian transfer. Let's get it into the tube so that peristalsis will carry it the same way that it would a normal fertilization. An ectopic pregnancy means that the early stage blastula implants within the fallopian tube rather than making it all the way into the body of the uterus. When that occurs, it is a medical emergency. That's why we go back to what was the significance of the ASIS. Halfway between the ASIS and the navel, the umbilical, you're on the appendix. But halfway between the pubic bone and the ASIS, you're on the ovary. And they are in such close proximity. A woman coming in doubled over, you have no idea what's causing the right lower quadrant pain. That's why first question one always has to ask, female patient over the age of 9 in New York State. Yeah, if she's there with her mother, has she started to menstruate? If she's older than that, when was your last period? I learned from my wife when she did admissions testing at White Plains Hospital, all females over the age of 9 have to have an HCG pregnancy test prior to surgery.
What?
And it just goes by. Why all? Because there are certain things daughters are not going to tell their mom,
Yeah.
no matter, at age 11, 12, these things do happen. My favorite story with her, she had a 38-year-old nun that got bent out of shape when she found out she had to perform in the cup to do a pregnancy test. And later on, after everyone heard the arguing, where my wife just very simply said, sister, you get 2 choices today. You either urinate in the cup and we do the test and you have your surgery, or you refuse to urinate and you don't have your surgery. You don't get 3 choices here. At the end of the day, they couldn't resist. They called, and according to the lab, the guy in the lab, wow, she's got such a high level, she must be 3 months into it. And it wasn't the almighty that crept in her nightie.
I was like, yeah. Did she not know she was pregnant, or she was in denial?
Yeah, she couldn't break one habit, so she gave up the other habit. And
Wow.
yeah, so there you go. But yeah, that's why it's always important to ask that and clarify it. So that again would be our fimbria, our infundibulum, the ampulla, the isthmus, and then that brings us to the uterus. The uterine wall is noted for an outer perimetrium. The muscular layer is called a myometrium. The innermost layer is the endometrium. The reason why it seems to have 2 colors, because this company really likes to be as correct as possible. There is a permanent base layer known as the stratum basalis. During the ovarian cycle, the corpus luteum will begin to secrete high levels of estrogen and progesterone, and that will stimulate the stratum basalis to proliferate and form what we call a functionalis. The functionalis is a highly vascular layer with temporary uterine glands that produce a super sticky mucus, so that if fertilization occurred, by the time an early stage blastula drops into the body of the uterus, it would stick to the side like crazy glue and then implant. The morning after pill, RU486, that's the French drug company's name for it, actually inhibits the production of the mucus. So it is not a contraceptive. It is basically some would describe it as a drug-induced, a drug-induced abortion. It's not preventing fertilization, it's preventing implantation. So that's why you got a lot of people who are pro-life that are against it. There have been pharmacists who refused to write the prescriptions because it was against their moral beliefs and they lost their jobs, sued, and were told by the judge, you don't have to work here. You want to open your own pharmacy, you can do whatever you want, but you work for CVS, Rite Aid, etc. Your job is to fill prescriptions and not make a moral standard on it. The top end of the uterus is known as the fundus, and then the rest of it is known as the body. The result of the development of the functionalis is that if pregnancy doesn't occur within 14 days following ovulation, the corpus luteum will shut down. Without the estrogen and progesterone, the functionalis degenerates and shed, and that's what we know as being the menstrual flow. The neck of the uterus is known as the cervix. When the cervix protrudes into the vagina, it creates a rim around it. So if you're looking at this model, we'd say there's an anterior and posterior fornix. That's right, there's a fornix in the brain and there's a fornix in the female reproductive system. If we were to look at a coronal section like we have the diagram in the lab manual, well then there is a lateral fornix. The best way to view it, it's a bit of a groove that surrounds the cervix. The opening to the cervix is known as the os. We would say there's a cervical canal and then an internal os. The lining of the vagina also is a ridged wall, and this is also rugae. And then of course we open up into the vestibule. Now, we will have questions on identifying perimetrium, myometrium, and endometrium. The interesting thing to note is how the lining of the fallopian tube, or the wall of the tube, and the wall of the vagina differ on their outermost layers. We give this the name perimetrium, but when we look at the tube, we have an outer, a muscular, and an inner lining. Wherever we look, the outer lining, if you're in the peritoneal cavity, is going to be a serosa. We're going to call the muscular layer a muscularis, and the innermost layer a mucosa. So we don't see it in our exam, but then when we look at the wall of the vagina, well, we have a mucosa, we have a muscularis, but now, because the outer wall is all in connective tissue, it's not really in the peritoneal cavity, so it's called an adventitia. So we'll just keep it to the 3 layers here. The nice thing is our diagram